Hi, this is Professor Steve Johnson presenting obstructive pulmonary disease, lecture number 2 from the pulmonary unit of the cardiopulmonary course for University of Wisconsin-Milwaukee PT program on behalf of Drs. Connie Kittleson and Dr. Stephen Johnson. As we talked about in the first lecture, pulmonary pathology is categorized into two major classification areas. The first being restrictive, where the volume of air is reduced. The second being obstructive, where air exchange is impeded. Again, I had used the analogy that when you think of a clogged pipe or a clogged drain, that is similar to uh, obstructive pathology, where air exchange is being impeded. One of the hallmarks of obstructive pathology is COPD, chronic obstructive pulmonary disease, which is characterized by an increased total lung capacity and an increased residual volume. What you see with COPD is a buildup of secretions, inflammation of the airway lining, bronchial tone or spasm, and a weakening of the support structure of the airway walls, preventing air exchange. This air sac destruction from overinflation or destruction of the body's ability to produce surfactant results in a condition where air exchange is being impeded and known as COPD. Again, I like this diagram. We looked at the restrictive lung dysfunction diagram, which showed a much smaller lung. I think, again, the illustration here shows that despite a larger total lung capacity, many times a larger functional residual capacity, what the patient experiences is a loss of vital capacity. Again, the importance of knowing the difference between total lung capacity and vital capacity. Total lung capacity is all the air that can be put into those lungs. And again, COPD patients, obstructive lung disease patients, oftentimes have hyperinflated lungs, a barrel-chested appearance, and a much greater total lung capacity than the average person. However, because the air that they can actually exchange is much smaller, they have a loss of vital capacity, which is the amount of air that they can actually use. And so again, I like this illustration because it gives you that visual representation of that hyperinflated lung and that large residual volume, resulting in an increased total lung capacity, but ultimately in a decreased vital capacity. So before we start to talk about the individual diseases, as we talk about what are some of the signs and symptoms of patients with COPD or obstructive lung disease, they are elevated shoulder girdle, horizontal ribs, barrel-shaped chest, and a low flattened diaphragm. And again, we've described those in previous lectures and talked about them in class, as well as, which is also abbreviated DOE, and eventually progressing to dyspnea at rest and a productive cough. Obviously, we looked at the diagram. We'll move to that diagram again. what happens to lung function with the hyperinflation is that you see a reduction in the O2 concentration because of all of this dead air space or residual volume in the lung. And because of that poor air exchange, eventually you start to see CO2 build up in arterial blood gas measures. And depending on the type and stage of disease, how severe the CO2 retention becomes in obstructive lung disease patients. One of the interesting things in this updated version of the Hilligus text is the amount of studies that have started to show that there are independent physiological changes that are starting to occur. We talk about COPD and obstructive lung disease in the context of what is affecting the pulmonary system and the inability of the body to exchange oxygen and carbon dioxide. Studies are now showing that there is also physiological changes that happen in other tissues beyond the pulmonary system and include a true decrease in muscle tissue density and type of muscle tissue, as well as the inability to tolerate activity. I will refer you to that section of the text to do some further reading. I find this very interesting because I think largely when I was educated in my PT program and the reading that I've done in prior years really looked at the all of the sequelae of results of pulmonary obstruction or restriction, that the loss of muscle mass, the loss of strength, all of those things were directly the result of the inability of the body to oxygenate. Uh, and and ultimately, I think some of these independent studies are now showing that the long-term effects of obstructive lung disease can truly have more physiological results than just with the pulmonary system. So now we're going to talk about the specific disease classifications that are put into obstructive pulmonary diseases. And again, it's a way of categorizing and a way to distinguish various conditions. But keep in mind that many of these conditions have some restrictive component to them. So just because they are categorized as obstructive diseases does not mean that they are exclusively obstructive. The ones that we're going to talk about today are cystic fibrosis, asthma, emphysema, and chronic bronchitis. We will then speak very briefly about bronchiectasis, which is classified as a obstructive restrictive lung condition. Again, I think it's a matter of categorization versus specifically knowing whether it is a restrictive or an obstructive disease or condition. So let's begin and talk about cystic fibrosis. Cystic fibrosis is a genetic disease. In fact, is the most common life-threatening autosomal recessive disease, um, and is characterized by a CF gene that affects a transport molecule in the lung tissue. It results in excessive mucus production in the lungs and result in bacterial infections because of the body's inability to clear those mucus plugs. So as we talked about, it's an autosomal recessive disease where both parents are required to be carriers. Children born to parents with the CF gene have a 25% chance of getting cystic fibrosis, but they also have a 50% chance of being a carrier. Unfortunately, there are numerous mutations and variants of the CF gene, making simple testing and screening very difficult. Although the physiologic process of cystic fibrosis is not fully understood, there are currently two strong theories as to what the influence of the abnormal CFTR protein does in the physiological sense. The first is referred to as low volume theory, where you have decreased molecular transport that results in tissue surface dehydration. This tissue surface dehydration reduces the body's ability to move mucus via ciliary action. And so you have a stagnation of the mucus, which in theory then results in increased infection. The second theory is referred to as the high salt theory, and this theory is that the presence of high salt concentrations limits the action of antibiotic molecules and allows bacterial colonization in the lung tissue. Either way, both have an end result of buildup of mucus and resultant infections. If it was just one infection, that would not be a big deal. But this is a case where, as young children, they begin to develop repetitive infections, and over time, as we've discussed and seen with the restrictive lung dysfunction unit, pneumonias and bronchitis infections can result in restrictive lung function, and over time, changes to the tissue. Multiple infections resulting in significant scarring and eventual destruction of that very fragile lung tissue. When pulmonary function testing, or PFT, results in an FEV1 decrease to 30%, there is typically a significant elevation of CO2 in the arterial blood gas, and this is considered end stage of the disease. When we look later at pulmonary function testing and talk about classifications for patients with emphysema or traditional COPD, that decreasing of FEV1 to 30% is considered very severe state of the disease, and typically patients have a difficult time functioning at all at that level, and typically results in death in the shorter rather than longer term. Some organs affected by cystic fibrosis include obviously the sinus and lungs, with the increase in infections and mucus buildup, as well as some other intestinal effects and major organ effects. For the purposes of this class, again, this is not a pathology class as much as a cardiopulmonary course, and so we're going to talk about the buildup of mucus in the airways. That buildup of mucus in the airways results in a colonization environment for bacteria, which results in infection, which results in immune response and injury to the tissue, which results in scarring, which results in further mucus buildup in an already constricted airway, which results in infections, which results in further remodeling and scarring, which results in further narrowing and loss of airway function. And again, this is where that consideration of it being an obstructive disease is that the airflow is impeded by that repetitive infection and scarring. Here's a histological example, again, looking at normal, puffy, sponge-like lung tissue with alveolar sacs, and then looking at lung tissue with resultant cystic fibrosis, with infiltrates, and loss of functional airway space. The next condition that we're going to talk about is asthma. Asthma is derived from the Greek word for panting, and asthma is the result of an inflamed airway from some type of immune response or sensitivity to environmental factors. The book goes into the great number of factors associated with asthma. What's important to note is that chronic inflammation can result in permanent fibrosing of tissues if the asthma is not addressed, and that the prevalence of asthma in society is increasing. And so the book talks about the many different environmental triggers, from exercise to cold air to uh, pet dander and cigarette smoke. The prevalence of increasing asthma condition, I give the numbers here, 3.1% in 1980 to 5.5% in 1996 to 7.3% in 2001, and finally the most recent numbers reported in the text, 8.4% in 2010. Along with the increased rise in asthma, there's been an associated increase in allergic conditions diagnosed as well. There are many theories as to what is causing this increase in asthma and allergies, but none have been fully proven or fully validated as the cause for this. Interestingly, this increasing prevalence is not seen in non-developed countries. So in lesser developed, or what is referred to as third world countries, there has not been this significant increase in asthma and allergies. And so one of the theories is that actually our clean living standards, lack of childhood infections, and lack of exposure to farming and high uh, high environmental insults environments as small children results in this susceptibility to having a inflammatory response when breathing in allergens. Here's a diagram of an asthmatic response. The response ends up being a dual response of a constriction of the smooth muscle that surrounds the airways. And so that constriction by the smooth muscle combined with increased mucus production impedes airflow. So again, why asthma is categorized as a obstructive lung condition is the fact that airflow is impeded as a result of constriction of the smooth muscles and the buildup of mucus in the airway, again, as a response to some type of irritant. Here's a cross section of that airway showing the normal open airway followed by a constricted airway because of smooth muscle contraction, followed by inflammation inflammation and a release of mucus. Next, we're going to take a look at, pardon me. Next, we'll take a look at a histological slide comparing a normal cross-section of an airway with one that has been affected by asthma. And again, you start to see that the increased development of hypertrophy of tissue And also you see the increased response of mucus and buildup of the airway, as well as a tightening and constricting, decreasing the lumen size, which will impede air exchange. I think one important thing to stop and note here is that although asthma is considered a, a obstructive disease, it is the only one of the obstructive diseases that is truly reversible with appropriate medication. And if you remove the irritant, the airways will return to their normal spacing and normal size, and the inflammation will reduce as long as the irritant is not reintroduced. However, if a person is left in a irritant-filled environment for a prolonged period of time and suffers without removing of the irritant or relief of symptoms, eventually, as with a lot of conditions, it can become chronic, and you can see permanent airway changes as a result of not addressing the condition. So again, we started to talk about this a few minutes ago. Asthma is the hallmark diagnosis of asthma, as opposed to other forms of obstructive lung disease, is the fact that asthma is reversible. And we'll talk about the reversibility percent with a bronchodilator. We will see a reduction of an improvement in the FEV1 of 12% or more, and an increase of 200 milliliters in a pulmonary function test in FEV1. And so again, person is tested, they're given a pulmonary function test, they then use a bronchodilator, and they are able to improve their FEV1 by 12% or more and increase in 200 milliliters of their FEV1, is considered a clinical sign of reversibility. So how should asthma be managed? Environmental behavioral modification, figuring out what the triggers are and removing those triggers from the person's typical environment, followed by medication. Corticosteroids are very effective in reducing the long-term effects of inflammation, and fast-acting bronchodilators are effective at reducing acute muscle spasms. And so the fast-acting medications are in two major classifications: the beta-adrenergics and the anticholinergics. And these relax the smooth muscle tissue, while corticosteroids, such as the ones listed here, reduce the inflammation. And so combination of a long-acting, long-term medication like a corticosteroid, along with a fast-acting smooth muscle relaxer for acute episodes, as well as removal of whatever's causing the asthma attacks to begin with, is the three steps for management of asthma. We're now going to discuss emphysema, which is the development of air pockets and a loss of surface area as a result of the destruction of the smaller alveoli. Emphysema is classified into three areas: central centrilobular, panlobular, and distal acinar, which is also known as subpleural. In centrilobular, you'll see a proximal dilation of the bronchioles, whereas in panlobular, you'll see a dilation of all of the air spaces. Of note, we're going to be talking a little bit further in the presentation about alpha antitrypsin deficiency, which is a genetic condition predisposing some people to the development of emphysema. Patients typically with alpha antitrypsin deficiency will develop panlobular type of emphysema. Distal acinar or subpleural, you see dilation underneath the apical pleura, and this type of emphysema is associated with large air pockets, and these patients often can develop what's referred to as a spontaneous pneumothorax, where the where the air pockets become so large that they actually can collapse the lung itself. Smoking is directly linked to emphysema and its development, and it seems to progress more rapidly in susceptible individuals, which indicates some type of genetic or hereditary component to individuals. And this is why you have that person who can smoke until they're 99 and never have any uh, emphysema development, whereas another person develops emphysema and lung tissue changes at a young age. What is clear is that smoking, when combined with other inhaled irritants, has a multiplicative effect, meaning that if a person develops emphysema from working near other toxic chemicals, if they smoke, they will have an even greater development, an even worse progression of their emphysema if they have smoking combined with other environmental irritants. So here's a diagram representation of emphysema, showing where normally you have these nice little bundles of grapes, uh, which are your typical alveoli. What you see is destruction of those individual alveoli, resulting in these large pocketed airways, which significantly reduces the surface area for air exchange. And this is what a cross section of a lung would look like with emphysema, with a much larger pockets of air, which again is not effective for air exchange, and so air exchange is going to be impeded because of a loss of alveoli. Whereas the other histological slides that we've looked at have shown a destruction of, again, the normal alveolar sacs. Again, it's always good to see the airspace of this very fragile tissue because that indicates air exchange. So you might be thinking, well, look, this tissue has even more air pockets and more ability for air exchange. And again, this goes back to usable volume of air versus a residual volume of air. The beauty of lung tissue is that there is lots and lots of surface area for there to be capillary interaction for exchange of carbon dioxide and oxygen. Instead, what you have is large pockets of air with very limited surface area in order for there to be adequate air exchange. A second obstructive lung disease is referred to as chronic bronchitis. Chronic bronchitis is the hypersecretion of mucus for a prolonged period of time, resulting in a clinical manifestation of bronchitis. This is not to mean that if you get bronchitis here and there that you have chronic bronchitis. Chronic bronchitis is clinically defined as 3 months of bronchitis per year for 2 or more consecutive years without any underlying disease states such as cystic fibrosis or tuberculosis triggering the buildup of mucus. Chronic bronchitis and emphysema, which we just discussed, are talked about together in what's referred to as COPD combination disease. In the clinic, when you see patients, they will often just be referred to as having COPD rather than COPD combination disease. So when you see a chart that says the patient has COPD, you can assume that they have emphysema and likely some component of chronic bronchitis. Here's a pictorial representation of a COPD patient with the chronic bronchitis, infections of the airway with mucus buildup, and inflammation of the airway resulting in impeding of airflow due to decreased lumen size, and that lumen being filled with mucus from repeated infections. Combined with small alveolar destruction resulting in loss of airflow, impeded airflow because of the inability to exchange the air in these pockets, these emphysema pockets. And obviously the artist adding in the number one cause and reason for development of COPD is that individual who smokes throughout their lifetime. I'll take a moment to stop here. I include this slide every year in my presentations. I think smoking is probably one of the largest destructive habits that you will see with your patients, regardless of age grouping that you work with, because oftentimes even in pediatric clients you will have children that are in homes of smokers that are exposed constantly to secondhand or passive tobacco smoke. I cannot emphasize enough the influence of smoking on the development of COPD and the destruction and cost to the healthcare system. And so again, any patients that you have who continue to actively smoke while suffering from COPD or from other health conditions, smoking cessation is a wonderful thing. The research is becoming more and more clear, and I try to be as positive as I can with my clients who smoke, that they're showing more and more positive results, that patients who choose to stop smoking can actually, over a number of years, actually reduce their risk for lung cancer, reduce their risk for development of COPD, and if they quit smoking at a young enough age, can actually return to what's considered normal values for risk of development of many of these diseases. This was often not the case in terms of what patients were told. And so a lot of patients have sort of a fatalistic belief that, well, I've been a smoker for 20 years, so what's the use in quitting? The damage is already done. And that's what many patients were told by their physicians or healthcare providers in the past is, well, you've already wrecked your lungs, so I guess what's the use of telling you to quit smoking? And again, the research is starting to bear out that in as little as 10 years after quitting smoking, many patients return to what are considered baseline risk levels for development of disease. So again, factors contributing to the development of COPD. Smoking, again, is the single largest factor worldwide. You will see in some underdeveloped areas, third world areas, that wood smoke or other coal burning stoves, those sort of things where people have to cook or heat their homes with smoke producing combustibles, they will see a rise in development of COPD. Alpha antitrypsin deficiency is a genetic susceptibility, and whenever you see COPD develop in a patient younger than 45 years of age, there's a high suspicion that they have a alpha antitrypsin deficiency that is being contributing to their emphysema. So, what are some of the signs and symptoms of COPD? Uh, Progressive shortness of breath with earlier and earlier onset of activity. It starts out as, boy, I can't do the stuff I used to do a couple years ago without getting short of breath, climbing steps, those sort of things. And pretty soon it becomes shortness of breath with just trying to get dressed, simple ADL activities. It's also, these patients will develop longer and longer respiration cycles because of a long expiration lasting longer than 4 seconds. They are doing everything they can to try to get air out of their lungs. Again, as we talk about that large residual volume that of air that's trapped in the lungs, they're trying to passively let as much of that air exhale before they inhale. These patients develop that barrel-shaped chest, which we've described several times. These patients will have an FEV1, which is a forced expiratory volume in 1 second of less than 80% of predicted. And their ratio of FEV1 compared to their entire forced ventilatory capacity will become less than 0.7. This is considered a hallmark threshold for non-reversible airway restriction. Again, patients with asthma may demonstrate an FEV1 of less than 80% and an FEV1 over FVC of less than 0.7. However, after taking their bronchodilator, they will see a 12% or more increase in the percentage, and they will also demonstrate a 200 milliliter increase in volume of their FEV1. Patients with COPD will also see a gradually increasing BODE score. BODE we'll take a look at here. I believe I have another slide that describes, yep. So we'll talk about that in a minute, as well as there's been a clear association with obstructive sleep apnea and COPD. And the thought is that these patients are already having enough respiratory difficulties. To add to it, obstructive sleep apnea is too much for the body to handle. And so patients with COPD are strongly encouraged that if they've been diagnosed with obstructive sleep apnea, to take all measures to prevent the stress of obstructive sleep apnea from contributing to their early demise. The gold standard for classification of COPD severity is the Global Initiative for Chronic Obstructive Lung Disease. GOLD is the acronym. Has staged COPD into 4 categories: mild, moderate, severe, and very severe, also known as stage 1, 2, 3, and 4. As you progress from one to the next category of severity, you see a gradual reduction in the ability of the body to produce that forced expiratory volume in the first second of exhalation. A normal person can exhale a large volume of their air, typically greater than 70% of all the air that you exhale in a normal situation is exhaled in the first second. So these patients will start to drop, and their FEV1 will become 80% or less of what is predicted for their age and gender, etc. When they drop from 50 to 80%, it will be stage 2, 30 to 50%. Stage 3, when they have less than 30% of the predicted ability to expire air during that first second, it's very severe, considered end stage, as we talked about with cystic fibrosis patients. All of these patients will be able to have an FEV below 0.7. But the staging mainly focuses on the various percent of predicted. Where are they at in the percent predicted, between that little bit greater than 80% all the way down to less than 30%. The BODE score, which I talked about earlier, takes into account body mass, obstruction value, dyspnea, and exercise tolerance. It results in a score ranging from 0 to 10. And I'm not interested in that you know how to calculate the BODE score, but understanding that it results in a score ranging from 0 to 10, and it includes body mass, obstruction value, dyspnea scale, and exercise tolerance. It's highly predictive of a patient's worsening COPD, and a score of 7 or higher. So if a patient is given a score from the BODE and that score is 7 or higher, it is predictive that that patient will expire within 52 months with a 80% mortality rate for patients scoring 7 or higher on the BODE. So let's talk briefly here about pulmonary function testing. And again, I already talked about the fact that FEV1 is the amount of air that you can expel from your lungs during the first second. The FVC is the forced vital capacity. They then like to do a ratio comparison. What is your FEV1 compared to your FVC? How much air can you exhale in 1 second as a ratio of the total air you can exhale? Normal is roughly 75, meaning that 75% of the air that you exhale is exhaled in the first second, while the remaining 25% is exhaled in the remaining time of the exhalation. So here's a nice diagram, and we will spend more time in class discussing pulmonary function testing and talk about some case scenarios. But this is what a normal FEV, FVC curve would look like. So a patient forcefully exhales the air, and what you have is volume on the vertical scale, and you have time on the horizontal scale. And so the dotted line represents the first second of air being exhaled. And so a normal patient, characterized here in red, has that sharp curve of 75% of their air exiting the lungs during the first second. You then have the remaining 25% of air exiting the lungs during the remaining time of the forced vital capacity exhalation. The other interesting thing to note here is the length of time it takes the patient to reach the completion of their FVC, which is denoted by this dot right here. So all the air that the patient can exhale has been exhaled at this point in time. When you look at COPD, you see very little air exhaled by the first second, and you see an extremely long passive exhalation, trying to get as much air out of the lungs as possible during exhalation. This is what's referred to as a flow volume loop, and we will discuss this in class. Finally, I will talk about bronchiectasis very briefly. Bronchiectasis is listed as a restrictive/obstructive lung condition. It is the irreversible dilation of the bronchi as a result of a variety of mechanisms, such as post-infection, injury, inhalation, congenital defect, genetic disorders such as cystic fibrosis, or the body's immune response. I will refer you to the Hilligus text. There's a couple of pages in there in chapter 6 discussing bronchiectasis. Again, I think we've discussed restrictive lung dysfunction and obstruction ad nauseum, but interesting of note is that bronchiectasis seems to be uh, a continuing diagnosis and even one that is on the increase in the United States, which has baffled some medical providers as to why bronchiectasis hasn't been reduced with better healthcare addressing some of these other causations. Finally, there is physical therapy intervention for patients with obstructive lung diseases, and those include improving compliance, improving lung volumes, and reducing the work of breathing. Again, we will spend time in lecture talking about these conditions. This concludes the Chapter 6 Pulmonary Obstructive Disease. Thank you for your time.